Hello, I'm Jean-Jacques Kiladjian, hematologist in Saint-Louis Hospital in Paris, France, and I will discuss with you today the future of interferon in MPNs, summarizing for you 3 important studies that were recently reported during the annual meetings of the American Society of Hematology and also of the European Hematology Association. So let's start with the results after 5 years of follow-up of the randomized controlled study PROUD and continuation PV that tested this novel form of monopegylated interferon alpha-2b, the ROPEG interferon alpha-2b, which is a single isoform with an innovative pegylation technology that allows the drug to remain stable in the body for a long time, allowing for just one administration subcutaneously once every 14 days. And this drug was approved in 2019 by the European Medicine Agency for the treatment of polycythemia vera in adults without symptomatic splenomegaly based on the results of the so-called PROUD and continuation PV studies. These studies, maybe you know, enrolled patients with polycythemia vera in need of cytoreductive therapy who were randomized to receive either ROPEG interferon or hydroxyurea. And as you can see on this slide, 127 patients were enrolled in each arm. After 1 year, they could continue their treatment in the follow-up continuation study. And as you can see, 95 patients on ROPEG and 76 patients on hydroxyurea entered discontinuation PV studies. And I will show you now what was shown at ASH, the 60 months interim analysis with efficacy data and safety also. The first finding that you can see maybe on the right side of this slide is that in terms of administration schedule, you can see that after the 3rd year, almost 40% of patients, and this remains stable until the 5th year of treatment, needed only 1 injection per month to achieve their treatment. So this is very convenient in terms of easiness of administration for the patients. In terms of efficacy, also, maybe you remember that this study showed, this is the red line, the complete hematologic response rate with patients treated with ROPEG interferon alpha that became superior to the conventional treatment with hydroxyurea after 2 years of treatment. And you can see that this difference remains durable over time. And after 5 years of treatment, we still have almost 56% of patients in complete hematological response in the ROPEG arm, compared to 44% in the hydroxyurea arm. Importantly, of course, for patients with PV, you can see that 81% of patients were phlebotomy-free during the 5th year of treatment with ROPEG interferon, this proportion being only 63% for patients receiving hydroxyurea. Of course, one important interest of the treatment with interferon alpha compared to conventional therapy is its potential ability to eradicate malignant cells. And this can be measured by the proportion of cells harboring the JAK2 mutation in peripheral blood, the so-called JAK2 V617F allele burden. And you can see that with ROPEG interferon, that's the red line here, there's a continuous decrease in the proportion of cells with the JAK2 mutation down to less than 10%, with a median of 8.5% after 5 years of treatment, while with hydroxyurea, after an initial decrease, then there's a rebound and the level remains very high even after 5 years of treatment. More importantly, after 5 years, we have now some patients, 5 of them, with completely undetectable JAK2 mutation below 0.01%. This is not achieved in any patients with the control treatment. And overall, we have 37 patients treated with ROPEG who achieved a diminution of their JAK2 mutation below 10% during treatment, this proportion being only 12% in the control group, so a big difference between these 2 treatments in their ability to reduce the JAK2 mutation and possibly to eradicate the malignant cells. In terms of safety, of course, we also want to be efficient in clinical events and mostly thromboembolic adverse events. And as you can see, very few patients experience a major thromboembolic adverse event during the treatment period in both arms, the incidence being similar between two treatment arms and very low, 1.2% patient here in each arm. In terms of disease progression, you know that PV may transform to myelofibrosis or myelodysplastic syndrome or acute leukemia. We were pleased to see, although the follow-up is maybe still too short to see a significant difference between the two treatments, but we were pleased to see that only one patient evolved to myelofibrosis in the ROPEG arm, compared to two patients who evolved to myelofibrosis and two patients who developed acute leukemia in the control arm. For the safety of treatments, you can see on this easy table that indeed there was no difference between ROPEG and control treatment in terms of adverse events, and even the frequency and the incidence of these adverse events decreased over time when you look during the 5th year of treatment, for example, on the right side of this table. The second study I wanted to share with you today is a study we did in my hospital, looking at the discontinuation of interferon in MPN patients to see if it was possible to stop interferon therapy, if this was safe and efficient. So in our hospital, we have a database with 1,243 patients with MPNs, and among them, 469 were treated at least 3 months with interferon during their disease, and 293 of these patients discontinued treatment, and we focused on the 205 patients who were in complete hematological response at time of interferon discontinuation, and we looked if first we could predict the ability to remain in complete hematological response after discontinuation, and also if it was safe in terms of risk of thromboembolic events and transformation to stop interferon instead of continuing interferon. You can see that this cohort of patients was well distributed with a slight female predominance, 56%. The disease type was half and half, almost PV, 47%, and essential thrombocythemia, 45%. And in terms of mutation, the vast majority of patients, 74%, had the JAK2 mutation. We looked at many factors to see which ones could be associated with the probability to remain in complete response after discontinuation, and we find indeed 2 of them. The first one was the median JAK2 mutant allele burden at time of discontinuation with a threshold of 10%, and the second was the time the patients remained on treatment after achieving complete hematological response, and the threshold here was 24 months. And as you can see on this slide, for patients who both had a complete hematological response that was maintained for 2 years on interferon and an allele burden of the JAK2 mutation below 10% at time of discontinuation, then the probability to remain in complete hematological response even 10 years after discontinuation was close to 40%. Then we looked if it was safe to stop interferon, and you can see that there was no difference in terms of risk of thromboembolic events between patients who stopped in red and patients who continued to receive interferon in black. The same for the transformation to acute leukemia or myelofibrosis with very few events, hopefully. And nicely also, you can see that the overall survival was very good for both groups, and no difference, again, for patients who stopped interferon and patients who continued interferon. And lastly, we wanted to see what happened for patients after discontinuation. You see that about 1/3 of them received no other treatment and remained in complete response without any treatment. 1/3 received another drug, and for 36% of those patients, interferon was restarted because they experienced a relapse of their disease. And after reintroduction of interferon, you can see that, again, it was really easy to achieve response, 80% of complete response, 7% of partial response. So overall, almost 90% of patients responded again to interferon. And the last study I wanted to summarize for you today is the so-called low PV trial that was presented by Professor Barboui at the last meeting of the European Hematology Association last June. And the study is now published for the first part of it. So in this trial, Professor Barboui asked the question whether the conventional strategy we use for patients with low-risk PV, meaning patients who are younger than 60 and who never had any cardiovascular events, you know that the current recommendation is to treat these patients with phlebotomy only and low-dose aspirin. And in this trial, it tested the addition of ropeg interferon alpha-2b to see the proportion of patients who were responders after 1 year of this one or the other of these strategies, meaning patients who maintain their hematocrit below 45% in absence of disease progression. So this endpoint was assessed after 1 year only of treatment, and then the patients were followed for the second year to see if these benefits were durable with a possible crossover from one arm to the other. And what was striking to see is that after 1 year of treatment, he could stop the study and the enrollment because the primary endpoint was achieved, with 84% of patients achieving this control of hematocrit without disease progression in the ropeg arm compared to 60% in the control arm. In terms of hematocrit control, you can see 84% of patients with ropeg had a control of their hematocrit compared to 66% in the phlebotomy arm, but more importantly, 8% of patients in the control arm experienced disease progression, while none in the ropeg arm, showing the superiority of this experimental strategy over the conventional strategy of phlebotomy only. Very interestingly also, this study showed that interferon was also able to improve the symptoms of patients with a diminution of about 21% of the symptom burden in the ropeg arm compared to stable or even an increase by 10% of the symptom burden in the standard treatment arm. So just to summarize, we know now that continuation PV study shows that ropeg interferon provides a long-term control of hematocrit, minimizes the occurrence of thromboembolic events and also hematological transformation with a well-known and overall favorable benefit-risk profile. In MPN patients, achieving at least 2 years of complete hematological response and a deep molecular response, meaning the reduction of the JAK2 allele burden below 10%, is associated with a good rate of maintenance of complete response without any therapy, and we can probably discontinue interferon therapy in these patients safely, and we are currently preparing a prospective trial to see, to confirm these findings. And finally, the results of the low PV study provide new evidence that may change our current management of patients with so-called low-risk polycythemia vera. Thank you very much for your attention.